did the investigator intervene? If the question is yes, it becomes an experimental study. The answer is no, it is an observational study. So we didn't intervene, it becomes an observational, you are just observing. Is there a comparison group? Yes, it becomes an analytical study. If there is no comparison group, it becomes a descriptive study. I hope it is clear for you. In experimental study, the basic question is, was there random allocation? We'll come to that a little bit more in detail. If it is yes, it is a randomized controlled trial. If there is no random allocation, it becomes a non-randomized controlled trial. We won't discuss NRCT. We'll discuss observational descriptive study, analytical study, and the RCT in a nutshell. So the descriptive study, the types are a case report. Okay, it's the least publishable unit in medical literature. Okay, you see a patient developing a 65-year-old or a 70-year-old or let's talk about a 35-year-old COVID patient developing stroke. A young patient who is a COVID patient, he had recovered from COVID, and within a month he developed stroke. Now that is an unusual presentation because he developed COVID and then stroke. That's a case report. That single case you can report, but it doesn't have much value in research. It's the least publishable unit in medical literature. But still, as students, definitely this is a big step in publication. If you can report a case in your student life, it's a big step.
Excuse me, sir.
Yeah.
Sir, so the PPT seems to have some issues. It's really cropped in. Is there uncrop it, sir?
Yeah, sir.
Yes, sir. Now it's visible.
Okay.
Yes, sir. Yes, sir. Thank you so much, sir.
Yeah. So
sorry for the inconvenience.
No, absolutely no problem. Please interrupt me if you're not seeing it anytime.
Yes, sir. Yes, sir. Thank you, sir.
So a side effect of a new drug, for example, remdesivir is a new drug which has come for COVID management. So if you can find a side effect which nobody has reported, you could make a good case report. As a medical student, especially if you are in your second year, you're doing a pharmacology, you can go ahead and report about a side effect of remdesivir in patients. So that is one. What about immunoglobulins? What about immunoglobulins in COVID patients? Again, you could make a case report on that. Okay. Another is unusual disease or syndrome in a patient. You could actually make a case report. The second one, this is a case report I've told you. Second one is the clinical series of cases. For example, you can report, the fever pattern in 50 COVID patients who had been admitted in your hospital. So that would become a clinical series. 50 cases of scrub typhus fever, which has been reported. It's quite rare, but now in Kerala we are seeing cases of scrub typhus for the past decade. So many people wouldn't have read about scrub typhus. So you could make a clinical series study on that. Okay, so you could say that 50% of the patients who presented with scrub typhus had a temperature of above 102 degrees Celsius. There was a male-female ratio of 3:1. And so on and so forth. So for these 50 cases, what are your findings? So that becomes a descriptive study. And then finally, a cross-sectional study. You want to find out the prevalence of diabetes in Thrissur. So you take the whole Thrissur district and you go out and check the blood sugar levels, and you find out the prevalence of diabetes in Thrissur district at one point of time. So you should go out and finish your study as soon as possible, probably around 3 months to 6 months. You take a sample of that population and take the random blood sugar, GRBS, and that will give you the prevalence of diabetes in your area. Fine. So prevalence of disease in population. Cross-sectional study will give you the prevalence of disease in populations. At this point of time, I would also mention there's something called a comparative study. Just for those who are interested, most of the PG theses are comparative study. For example, let us talk about diabetes. Those who are receiving glimepiride only, and those who are receiving glimepiride plus metformin. You're just looking at, what are the blood sugar control levels in these two group of people. Okay, so, and then you make a study on that. You're not intervening, you're not giving any drug. Somebody else is giving the drug. You're looking at the charts. You come out with, the effect of metformin and glimepiride in one group of people, and metformin and glimepiride only in the other group of people. And then you say that adding metformin actually increases the blood sugar control levels and so on and so forth. So a comparative study can occur in a descriptive study, where you are just observing and you're just making comparison of two groups of patients. So descriptive study, basically you go for time distribution, place distribution, and person distribution. Example, again, I would talk about the Nipah epidemic, which happened in 2018 and 19. So the time period was April. In 2018, it was between April, May and June. Okay. So in 2019, we were very vigilant. It would occur in April, May and June. And we got a few cases of Nipah during that point of time. So that is time distribution. So many factors could be there. It is the fruiting season, the bats feed on fruits, and that is why probably, we are getting more cases of Nipah during that point of time. Where is it occurring? Okay, it actually started in Malaysia, then came over to Bangladesh, Bengal, and finally it reached Kerala and Calicut, and then we had one single case in Ernakulam. So that is a place distribution. You talk about cancers, again you will have place distribution. A particular area will have more cases of CA lung or kidney renal cancers when compared to some other populations. For example, Japanese may not have renal carcinomas when compared to our Kerala population, and so on and so forth. So who's getting the disease? Are males more dominantly getting the disease? Are females getting more? Or are children getting more? For example, Japanese encephalitis is more common in adolescent population, okay? And whereas leptospirosis is more common among agricultural population, and so that is the person distribution. Now we come to the analytical studies. Analytical studies are of two types: the case control study and the cohort study. Okay. Case control studies are one of the easiest to conduct when you look at it from very far, but actually it could be the one of the most difficult studies to conduct per se, because there is something called bias involved, and you could also manipulate the study very easily in case control study, and that could be found out by great reviewers who reviews your article when it goes for publication. So case control study can be done very quickly. You can finish it off very fast, but you have to be very careful. So let me try to highlight where you can go wrong. Okay. So first of all, I'll tell you where case control studies are done. Case control studies are done where the disease is rare and the exposure is common. So especially carcinomas, cancers are quite rare, but the exposure is common. For example, cigarette smoking and renal cell carcinoma. Okay, so the cancers are quite rare, but the exposure of cigarette smoking is quite common. So this is where you can actually do a case control study. So how does the case control study design occurs? The disease has already occurred, and the investigator goes back in time and finds out what and where it happened. Okay. The best example that I can quote is diethylstilbestrol. Now, diethylstilbestrol, DES, was a contraceptive. Now, I wouldn't say it's a contraceptive. It was a steroidal hormone, estrogen, used in early 50s and up to late 70s for not birth control, but for pregnancy-related complications. Okay. To prevent premature pregnancy and so on and so forth. Now this drug was so successful, they started using it very commonly. Now, one gynecologist started getting clear cell adenocarcinoma of the vagina in adolescent girls aged between 14 and 16. Now, CA vagina is very uncommon in such age group. Okay, so then this gynecologist started suspecting something very unusual. Something is wrong here. So then they did an investigation. They did a case control study, and they found out that the mother of this child, mother of this adolescent child, took DES when she was in pregnancy, and that is how this cancer developed. They found out there was a 35 times the chance of developing CA vagina in those mothers who took DES in pregnancy when compared to the normal population. So then this led to the banning of DES, and DES was totally banned. So this is the importance of case control study. If a case control study was not done at that point of time, probably cow's milk could have been blamed for this vagina, or some other, the child went to this school and that is why he developed CA and so on and so forth. Any reason could have been given. But since they did, can you imagine, they went preterm, they went to the mother and started asking history. From the adolescent, they went to the mother, they went to the pregnancy and looked what are the drugs they were taken, and that's how they arrived at diethylstilbestrol. And finally, it was banned. So choose groups with and without the disease, looks back in time to what different exposures they may have had. Fine. So how does a case control study work? The investigator selects the case with the disease and appropriate controls without the disease, and obtains data regarding past exposure to possible etiological factors in both groups. Okay. So you have a case definition. Suppose you are studying renal cell carcinoma. Okay. So you have a definition whereby you say histopathologically proved cases of renal cell carcinomas are your cases. Fine. So they are your case. Now controls are going to be the problem in case control study. It is very easy to get a case because you have a case definition, you get a case. But controls, you are very difficult to get a good control, because we'll come to that later on, why controls are difficult. Now, definition of the case, once established, they should not be altered or changed till the study is over. Now, you have made for renal cell carcinoma, you have made a histopathological definition. In between the study, you find that histopathological reports are taking over a month to get. So what you do, you look in the theater table itself, you decide this is renal cell carcinoma and I will take this as my diagnostic criteria. That is not possible in any point of any study. Once you keep a diagnostic criteria, you must stick with it. You can't change it in between. Okay. Eligibility criteria is a requirement that only newly diagnosed cases should be included in case control study. Okay. You cannot include prevalent cases. For example, a renal cell carcinoma was diagnosed 2 years back. He's on chemotherapy. You cannot include him. You must diagnose incident cases, newly diagnosed case of renal cell carcinoma. So, as I told you about the problem with controls, the control should always come from the study population. Now we are studying renal cell carcinoma in Thrissur district of Kerala. Okay, so ideally these controls also should come from the same population, right? Suppose one renal cell carcinoma patient presented to you from Andhra Pradesh. Let us say he was a person from there, from Andhra Pradesh. He had just come for a visit. Suddenly he developed some symptom and he had just come for a checkup, and you have diagnosed him as renal cell carcinoma. Ideally, the control should come from his native place, that is Andhra Pradesh, from his village, wherever he was. The control should come from there, because the etiological factors involved in Andhra Pradesh and Kerala could be totally different. Okay, second criteria should be the control should be free of the disease, and the third criteria should be very similar to the cases as far as possible. This is never possible. How can a case and control be similar in all aspects? It's not possible in theoretically, but you could actually do some matching, and you could actually take the same age group. For example, a 30-year-old male coming with renal cell carcinoma, you could take a control who's aged 30 years, a male presenting, 30-year-old male presenting from Thrissur district. So your control would be a 30-year-old male coming from Thrissur district, okay, but is free of renal cell carcinoma. So that is called matching, okay. So matching in a sense, actually you want to select, same characteristics of that case. The control should be of the same characteristics of that case, but he should be free of the disease. For example, if I was studying the risk of NSAIDs and colorectal carcinoma, okay, I would go. In the hospital, I get a colorectal carcinoma. That is my case. So he's a 60-year-old man. So I go to the ward. I go to the ortho ward. Okay, I go to the ortho ward and select a 60-year-old man with colorectal carcinoma. Now, what happens is in ortho ward, everybody is on NSAIDs. So there is a little bit of bias creeping in there. So you have to be very careful in selecting controls in a case control study. So selecting case control study, selecting controls in a case control study is one of the most difficult tasks in epidemiology. It is very easy to get, carried away and select controls as and how you like, but it is one of the most difficult tasks in epidemiology. Now there's something called the confounding factor in case control study. Okay, I will just explain it by giving you 2 examples. This is associated with exposure and the disease. The confounding factor is associated with the exposure and the disease. For example, alcohol. You want to study the effect of alcohol on CA esophagus. You want to study the etiology of CA esophagus, and you say that alcohol is one of the causes of CA esophagus. But smoking is a confounding factor. Why smoking is a confounding factor? Smoking can cause CA esophagus, but it is also seen that most alcoholics are also smokers. So how do you know that alcohol per se is causing CA esophagus? It could be smoking per se which is causing CA esophagus. So that is called a confounding factor, where smoking is associated with the exposure and the disease. Okay. The second example, again, it was found. This is actually findings. Okay. You want to study the effect of oral contraceptives and myocardial infarction. Here again, smoking is a confounding factor. This was the earlier studies when OCPs were introduced. It was found that smoking causes myocardial infarction. We all know that. But it was also found that those who took oral contraceptives, those females who took oral contraceptives were also smokers. Okay, fine. So this is what is called a confounding factor. Matching, I have just mentioned again, it's a process of selecting controls so that they are similar to the cases in regard to certain characteristics such as age, sex, and neighborhood, done to ensure comparability between cases and controls. It is usually done in pairs. It is usually, the dictum is, you want to increase the power of the study. Okay, I'm not going to discuss what the power of the study is, it is beyond the scope, but let me tell you, usually in a case control study, for every case, you select 2 or 3 controls, maximum 4. But it is ideal to select 2 or 3 controls. Suppose you get 100 cases, 1 case of renal cell carcinoma, you are supposed to take 2 controls. So that is called the ratio, 1:2. So for every 1 case, you take 2 controls. Ideally, we take 2 controls, but we don't never take more than 3 or 4. And it's not usually done for one case, we don't take 1 control. It is always 2 or more, but definitely less than 4. Okay, so it is done usually for age, sex, and occupation. Okay, bias is very important. You as medical students, you must know what a bias is in a research methodology. Okay, bias is very common now. There were studies reported by prominent journals, for example, NEJM, Lancet, on the effect of hydroxychloroquine. I think all of you must have read about this. This is something about bias. You are manipulating your studies so that the study, is found to be very relevant and can be published as early as possible, as fast as possible. So that is bias. Can be intentional, which is why they were punished in the US. but it can also be unintentional also. You don't know when bias creeps in. So bias is any trend or deviation from the truth in data collection, data analysis, interpretation, publication, which can cause false conclusions. Okay. Let me give you a very good example in clinical trials. We are talking about case control here, but clinical trials, where I can show you, where I hope you will understand what a bias is. See, I have around 100 COVID patients with me. I'm the treating physician, I'm the investigator. I have 100 COVID patients, and I want to show that my drug, I have discovered a new drug. For example, let us say the drug XYZ, which has been a fantastic drug. When I give it, patients start improving dramatically. They come out of category C, and the SpO2 goes up to 95, then suddenly it goes up to 98. From 75 to suddenly increase. It's been a wonderful drug, and I want to prove that my drug is very effective. So what do? I go into the ward. I see 20 COVID patients admitted there. One person is around 70 years of age. The other person is 25 years of age. The 70-year-old man is gasping, whereas the 25-year-old person is, his SpO2 is around 92 in ambient air. What do? I give this fantastic drug XYZ to this young person, whereas I give the, placebo to that patient, that old man. So what happens? There is bias creeping in, because what happens? This young person will definitely improve on his own because he's young. He's not having that much respiratory failure, whereas this person, this old person who's been treated with the placebo, will have a very bad prognosis. So I am manipulating my own selection of cases so that I will get a fantastic result with my drug XYZ. And that is happening, believe me, that is happening. Why? Because the pharmaceutical companies are pumping in enough and more money to make their drugs, most effective drugs when compared to the other drugs. So this is where the bias creeps in. And that is where the randomized controlled trials are the gold standard for any clinical trial. So we come to that later on. So I hope you have understood what bias is. It is immoral, okay, because you are manipulating your study so that you get a very fantastic result. Okay, there are many different types of bias. I'm not going to all types of bias. Just for the sake of you hearing it, I'm just mentioning it. Bergsonian bias, Neyman bias, Hawthorne effect. I just talked about Hawthorne effect. Hawthorne effect is where the study subjects, you're putting the cases on dexamethasone. That patient knows that he's in one of the study subjects. He's receiving dexamethasone. So he develops a behavioral change because he wants to impress the doctor who's treating him that the drug he's giving is very good for him. So he says that I'm feeling much better, my fever is gone, or I don't have diarrhea now, and my respiratory things, that is called the behavioral change because the patient knows that he's been administered the drug. So that is what is called the Hawthorne effect. This you must know because the subjects may start, playing with you when you do as an investigator. So this is called an Hawthorne effect. There is something called information bias, that is recall bias and interview bias. I think again as medical students you must know this. You want to prove that, for example, you want to prove that inhalation of cadmium, okay, inhalation of cadmium can cause renal cell carcinoma. Cadmium was used among goldsmiths, and inhalation of cadmium can cause renal cell carcinoma. So you're going to do a study and you find a person who has renal cell carcinoma. You ask him, did you as a goldsmith, did you ever use cadmium while, did you ever use cadmium? He as a patient will recall immediately. Why? Because he's a patient, he's been diagnosed of cancer, he's sitting alone in his room, he will say, why I got it, why nobody else got it, why me? Whereas my friends, nobody got renal cell carcinoma. So he'll say that it must be that cadmium compound that I used when I was working as a goldsmith 20 years back. So this is the recall bias. Whereas a control, if you ask him, did you use cadmium? No, I never used cadmium. Okay, so he will say, no, he didn't use. Now there's something called the interviewer bias. Now what the interviewer does is, he keeps asking, no, just remember when you were working as a goldsmith 25 years back, remember you used cadmium? No, I never used. No, just think you used. Yes, I remember I used it once. So that is what is called interviewer bias. So there's recall bias and the interviewer bias. So this is where, bias really creeps in. This is what we call bias. So now we come to the analysis in case control study. The main measure of association commonly associated with case control study is the odds ratio. I think most of you would know about odds ratio. It is given by this 2x2 table where you arrange A, B, C, and D. And the cases and controls are on top, as you can see. And the exposure. The cases are renal cell carcinoma. Controls are those controls you have taken. Exposure is the cigarette smoke or the cadmium, and those who are not been exposed to cadmium. And you get odds ratio by simply multiplying AD by BC. Okay. So there are other names for odds ratio. Relative odds, cross product ratio are all synonyms of odds ratio. What does odds ratio mean? An odds ratio of 5 means there is 5 times the chance of developing renal cell carcinoma to those who are exposed to cadmium when compared to those who are not exposed to cadmium. So odds ratio of 5 means there is 5 times the chance. If you get an odds ratio of 1, what does it mean? It has no relationship at all. It's neither protective nor at risk, nor an etiological factor. If you get an odds ratio of 0.75 or 0.5, it actually means that cadmium is protective against renal cell carcinoma. Okay. There was this one fantastic study done by one colleague of mine. In his analysis, he found that alcohol was slightly protective. He got an odds ratio of 0.8 when he was studying the effect of alcohol on myocardial infarction. So in his presentation, he had to say that alcohol was actually protective against myocardial infarction. But we all know that it isn't. It's not like that. But a study is a study. You cannot manipulate your data. So he presented it like that too. So this is the importance of odds ratio. Now we come to the second analytical study, that is the cohort study. Cohort is derived from a group of people who have the same characteristics. It was in the Roman army. They had people who had a definite height and chest circumference. That is, they should have around 6.5 feet in height and a particular chest circumference. Only then they would be in that cohort, in that army or that army unit. So that's how the word cohort came in. Okay, a group of people who share a common characteristic or experience within a defined time period. For example, same age, those born in the year 1985, those born in 1990, the batch of 2016, the batch of 2018. You're all a cohort because you all joined in a medical college at that particular time. Those doctors, those healthcare workers, they're all cohorts. So exposure to a drug or a vaccine. Those infants who were given rotavirus in March, so they become a cohort. So these are the examples of cohort. Okay. Now, how does a cohort study progress? Okay. You take a source population, you take sampling. Okay. In cohort study, it's usually done where the exposure is rare and the disease is common. Okay. We do a cohort study where the disease is common, but the exposure is rare. Whereas case control studies are done where the disease is rare and the exposure is common. So what we do is we have those who are exposed. It's a prospective study. That means you are going forward in time. The cases have not yet come. You're going to get cases. So what we do is we take a group of 10,000 doctors. Let us assume we take a group of 10,000 doctors. Those who are exposed to X-ray radiation, those who are not exposed to X-ray radiation. Okay. Well, let us take X-ray technicians, 5,000 X-ray technicians, and those who have got exposed to radiation above certain symbols, and those who didn't get exposed to certain level of symbols. You can categorize them into 2 groups. Another example would be cigarette smoking and those who did not smoke. Okay. So in the exposed group who developed lung cancer, who did not develop lung cancer, who developed in the non-exposed group who developed lung cancer, who did not develop lung cancer. Now the problem with cohort study is it takes time. It takes 5 years, 10 years, 15 years. So if it follows smokers and non-smokers, it will take 10 or 15 years for them to develop lung cancer. So this study has to go on for quite a long period of time. So that's why cohort studies are called a prospective study, whereas a case control studies are called the retrospective study because we are going back in time. Of course, there are different other types of cohort study. But at this point in time, I don't want to confuse you with certain terminologies, so I'm not mentioning those, okay? Because you will all get confused. So think of cohort study, which is prospective, which is going forward in time. So what are the features of a cohort study? Cohorts are identified prior to the appearance of the disease under investigation. The study groups so defined are observed over a period of time to determine the frequency of disease. So you're going forward in time, you're observing when they develop lung cancer, how long it took for them, whether smoker or non-smoker group. Okay, so you get them. And okay, I've told you this, when the exposure is rare, but the disease is high among the exposed. Okay, so what all data will you get when you analyze a cohort study? The first is incidence rates. For example, you get the incidence rates of CA lung in smokers, incidence rates of CA lung in non-smokers. So this is the two incidence rates you will get. Okay, another rates you get is the relative risk. Relative risk is similar to the odds ratio and case control study. What does it show? A relative risk of 10 indicates that the incidence rates of disease is 10 times higher in the cigarette smoking group when compared to the non-smokers. Okay, something like the odds ratio in case control study. Another very important risk index you get is the attributable risk. To what extent the disease under study is due to exposure. Okay, 20% of the smokers will develop lung cancer. Okay, so that is, you are attributing of all the lung cancers, 20% is due to smoking. So that is what we are telling. And there's something about the population attributable risk. Population attributable risk is for program managers who want to talk to politicians and somebody like Bill Gates, Melinda Foundation. You want to approach them for funds. You must have a population attributable risk with you. And you can go to them and tell, if you are able to stop smoking, 90% of the cancers of lung will be abolished. Okay, can be stopped. 90% of the cancers is due to smoking, and if you can bring a law to stop smoking, 90% of the cancer due to lung will not happen. So that is population attributable risk. That is very important when you are a program manager and you want to approach for funds. Okay, again for funds you can say, if rotavirus vaccine is introduced, now of course it's introduced, we can bring the incidence of diarrhea by around 70%. One in 5 infant diarrheas are due to rotavirus, and around 20% of the diarrheas can be stopped if you can just bring in a rotavirus vaccine. So these are, I'm saying in another way, but this is what a population attributable risk is all about. Now we come to the gold standard of all studies, that is the experimental study. Of the experimental study, it is the randomized controlled trial. The 2019, the Nobel laureates in economics, Abhijit Banerjee and Adolph, they got the Nobel Prize in economics because they did randomized controlled trials to prove that economics is good or bad in particular population or not. So because of RCTs they have done, they got a Nobel Prize. So that's how important an RCT is. Okay. So in an experimental study, the researchers have a control over key variables in the study. It's a gold standard in research. Okay. Now, how do you do the randomized controlled trial? From the let us talk about dexamethasone in COVID patients. Dexamethasone in COVID patients. So the source population is COVID patients. Okay. Now there must be some people who are not eligible for dexamethasone because they must be in category A. You don't need to give dexamethasone in category A. So those people are not eligible. They must be having some other underlying disease. For example, they are already steroid dependent, or probably their prognostic factors different, or they already have comorbidities like diabetes, hypertension, etc., and they're quite serious. So you're not justified in giving dexamethasone in diabetes patients, so on. So due to many factors, you can exclude those patients, and you include those population of patients who really deserve dexamethasone. For example, category C patients who their SpO2 levels are going below 80, and you need to give something urgently to actually to give this. So again, I come to that bias where, as an investigator, I go into the ward, I see a 70-year-old man who's gasping and a 25-year-old man whose SpO2 is around, say, 85. I would definitely give Dexa to that person, to this young fellow, rather than giving this thing. So what happens is, this is where bias creeps in. So once you randomly allocate, you're eliminating bias. Randomization is the step to eliminate bias. Okay. So what is randomization? I'll come to later on when I show you the random number table. I'll explain it a little more. Here we give the drug, the exposed is the drug, you give dexamethasone. To the other we give a placebo. Okay. Now again, I'll come to what blinding is in later on. Okay. Well, in dexamethasone people, those who are cured or those who worsened, there are two groups there. In those who didn't receive dexamethasone, again two groups are there, those who got cured and those who are diseased. So these are 4 groups of people you will get when you give a drug and a placebo. Okay, I'll come to randomization a little later on. There are different types of clinical trials. That is the parallel design, which we talked just now. You give a drug and a placebo and goes over. There's a crossover design. Okay, crossover design is you're giving dexamethasone in one group of people, remdesivir in the other group of people. Okay, after 2 months, okay, we cannot talk about that in COVID. We'll talk about that in diabetes mellitus. Let us say you want to study the effect of metformin and glimepiride. Okay, you give metformin in one group of people, the other you give glimepiride. After 2 months, there's a washover period. You stop both drugs. There's a washover period. To group A, you give glimepiride. Now to the other group, you give metformin. So you're crossing over the drugs. And what happens is all the participants in that group receive a drug at one point of time. Either they receive at the beginning or at the end. So this is called the crossover design. It's a good design to see which drug is better than the other drug. Now there's something called the factorial design. That is excellent for doing a study on 2 drugs at the same point of time, simultaneously. Okay. Suppose you have 100 COVID patients. In this 100 COVID patients, to one group you give placebo, to one group you give remdesivir, to one group you give dexamethasone, and to the other group you give both remdesivir and dexamethasone. So in one study itself, you are studying 4 groups of people. That is placebo, drug A, drug B, and drug A and B together. So that is called a factorial design. It is a very good design. It is done very well nowadays, and there are a lot of factors in analysis. Analysis of factorial design is quite difficult, but it is an excellent study design in RCT. Multicentric trials are you doing the same study in multiple centers. For example, AIIMS Delhi is doing it, AIIMS Bhubaneswar is doing it, AIIMS Andaman and Nicobar is doing the same study, and that is multicentric. And then you collate the data and you come out with the final study results. So these are the types of clinical trial. So first step in RCT is the protocol. You make a protocol. Once you make a protocol, you can't go about it. You can't go sideways about it. For example, you talk about the diagnostic criteria, you talk about the eligibility criteria, who should be included, who should not be included, the inclusion criteria and the exclusion criteria, and so on and so forth. And once you select that, you have to select the experimental populations. For example, COVID positive patients, category C would be your experimental population. And the third one is the randomization. So randomization is the investigator does not know which group is going to get DEXA and which group is going to get the placebo. Okay, placebo is just a vitamin which appears similar to the drug like dexamethasone. Suppose dexamethasone is white in color and appears round. Actually, the placebo also should be white in color and should appear round, because these 2 patients are sitting side by side and they will compare their medicines. And that patient will know that I am receiving remdesivir and he is receiving placebo. So to make the patients blind, even the medicines have to be, should appear similar. So randomization, you can do it by computer generated random table. which I will show you later on. So once the first patient comes with COVID, suppose it's an odd number, all odd numbers will receive remdesivir or dexamethasone. All even numbers will receive placebo. So this is a computer generated table, and according to that odd number or the even number, the patient will receive the drug or the placebo. Fine. So nobody knows what the next patient is going to get, because it's a computer generated table which is going to decide, the drug or the placebo which the patient is going to receive. And then you intervene, you give the drug, and after that you follow up the patient, and then you assess the outcome of the patient. So randomization is the heart of the trial. Okay, it is an attempt to eliminate bias. Still, bias may come in. As a very clever investigator, you can go around this blinding and everything and try to find out who's getting what. See, that is all immoral. You should not do that. As an investigator in a randomized controlled trial, you must follow the protocol and you must go accordingly. Okay, and the investigator has no control over allocation to either study group or the control group, and this eliminates what is called the selection bias. Okay, this is the random table. This is a computer generated random table. Now the first number is 76, so it's an even number, so that person will get a placebo. Second is an odd number, that person will get the drug. Second even, third odd, fourth is 51, which is odd, fifth is 45 odd, 92 is even. So nobody knows who's going to get what. Even the patient does not know, the investigator does not know who's going to get what. So this is called randomization. So randomization eliminates bias, and that is the heart of the trial. So randomization is difficult, and just talking on randomization takes 1 or 2 hours. There's so many combinations of randomization. The great researchers, even today, they say we still haven't learned what randomization is. That is after publication in NEJM, and those experienced researchers, they still say we do not know what randomization is. For example, one Dr. Dennis is there in St. John's, Bangalore. He was telling us the other day, after even publishing more than 20 articles in Lancet and NEJM, he still hasn't come to comprehend what randomization is. There's so many combinations and analysis and all this. What I'm telling you now is just the base of randomization. There's so many other things to talk about randomization. I hope you have understood what randomization is and how we can eliminate bias due to randomization. Okay, blinding. I told you before, the participants should receive the drug which are similar in size and shape, because when they are lying together side by side, they should not find out who's getting the drug and who's getting the placebo. So the single blind studies, the participants are not aware of what they're going to get. Now, before I say all this, the most important part is the ethical part of this. I have not talked about ethics in this. You must take a consent. Now it is mandatory that video recorded consent should be taken before you do an RCT. Video recorded consent, not that you get that person to just simply sign and finish it off. You must explain to the patient that you are going to get a placebo or a drug, which is a new drug. There may be side effects associated with this new drug, and so on and so forth. And only then get a signature. And this video should be kept in archives for minimum of 3 to 5 years. And anytime anybody can come and ask for this and say, let me see your consent. So this should be cleared through the ethical committee, and ethical committee should give you a permission to go ahead with the study. Okay, with that I come to what I finished with single blind study. In the double blind study, it's both participant and the investigator are not aware what is being given. Okay, so the investigator also does not know whether the patient is getting dexamethasone or the placebo. He just comes daily for rounds. He just sees the patient, checks the patient, fever pattern, what is his oxygen saturation, X-ray, and so on. Just treats the patient and goes. At the end of the study only, he will come to know the results. So that is what is called the double-blind randomized controlled trial. So double-blind randomized controlled trial is one of the gold standards of research. And I would I wouldn't say I would request, or I would be extremely happy of the 200 odd participants who are there, who are listening to this right now. If even if 2 of you could do a randomized controlled trial in your whole lifetime and is published in a reputed journal, that would be a great achievement on this for those organizers of this quest, for this explore. That is how difficult it is to do a randomized controlled trial. But it is not impossible. It is difficult indeed, but not impossible. So in triple blind, the analyzer is also blind. So let me just tell you what happens. Okay, the patient walks in with COVID. Okay, there is a investigator. Okay, so the investigator is blind. So what he does is he diagnoses this patient as COVID and sends it to another person who's the analyzer, or the who's the co-investigator, who looks at the random table and tells this patient will get remdesivir, and he gives him remdesivir or dexamethasone. Whereas the the principal investigator does not know whether he is getting this and this. Okay. The analyzer is the person who actually tallies all these results. Even he does not know who's receiving what. It is only the data which he receives. Okay. I'm coming to the end of my presentation, another 10 minutes. 100 childhood asthma cases are randomized, 60 were cured, 20 dropped out, 20 still have the disease. So proportion cured is 60 by 80, and B is 60 by 100. Okay. Now, when you analyze, there are 2 types of analysis. That is the intention to treat analysis and the per protocol analysis. Okay. Intention to treat analysis is where once you have taken 100 asthma patients, they may drop off due to many other reasons. For example, there may be a mortality, or they may have migrated somewhere. They have developed side effect to the drug. They don't want to take the drug anymore. So they just drop out of the study for many reasons which are innumerable. So in intention to treat analysis, we include those patients also who dropped out. Fine. So that is a pragmatic trial. You are looking at the effectiveness, because when you go and introduce this drug to the population, due to many factors, this drug may not be acceptable to that population. Okay. So intention to treat analysis is very good, because you're including every patient who's included in the study. The very next day he may drop out. You're included in the study, and the very next day he says, I don't want to be in the study, I'm just dropping out. So that patient also you should include in your analysis. In per protocol analysis, you don't include those dropouts. You just take those who have completed the treatment. You don't include the dropouts due to mortality or something else. You don't include them. You just take those who have dropped out of. You include only those who have completed the treatment at the end of the study. Okay, I hope you understand this. It is very important. These 2 terms are very important in RCT. I hope you will read up more on intention to treat analysis and per protocol analysis. So in intention to treat analysis, once randomized, always analyzed. Once you enter the study, you are analyzed. So it includes every subject who is randomized according to randomized treatment assignment. It ignores non-compliance, protocol deviations, withdrawal, and anything that happens after randomization. Whereas per protocol analysis, you include only those who have completed the treatment. Okay, in analysis, this is a very important term that you will hear in future, and probably have started hearing it. It is the NNT and the hazard ratio. I won't discuss hazard ratio here. I will just mention NNT, number needed to treat. Suppose you are looking at hydroxychloroquine, the effect of hydroxychloroquine in 100 category C COVID patients. Okay. In 67 of them, there was no respiratory failure anyway. We are looking at category B and C. Okay, I will just put C. So categories B and C, 100 COVID patients. 67 of them did not have any respiratory failure anyway. But what happened is, in those whom you gave hydroxychloroquine, you were able to prevent around 11 respiratory failures. Okay, because with treatment there were 33, without treatment, in the treatment group, there were only 22 people who developed respiratory failure. So you could say that you prevented 11 respiratory failures when you gave hydroxychloroquine. All these are theoretical. I'm just mentioning in hypothetical situation. Okay. So after treating 100 COVID patients, you prevented 11 respiratory failures due to hydroxychloroquine. Okay. So when you treated 9 patients, you prevented 1 respiratory failure. So, okay, fine. This is how the data is calculated. It is actually called NNT is 1 by absolute risk ratio. That is how 9.1 goes by 1. 100 by 11 is the absolute risk ratio, and NNT is 1 by ARR, that is absolute risk ratio, that is 9.1 by 1. So what do you say, NNT? We need to treat 9 persons with COVID with hydroxychloroquine to prevent 1 respiratory failure. We need to treat 9 persons with COVID with hydroxychloroquine to prevent 1 respiratory failure in your study. Now, suppose they find another drug. Let us see remdesivir. Remdesivir needed to treat just 5 persons with COVID to prevent respiratory failure. So, which is better? Remdesivir is better, because to prevent 1 respiratory failure, you just needed to treat 5 people, whereas hydroxychloroquine, you needed to treat 9 people to prevent 1 respiratory failure. This is what is called the real evidence-based medicine. This is all evidence. You are presenting evidence to say that remdesivir is better than hydroxychloroquine. I'm talking all relative hypothetical things here, but just for you to understand that NNT of 9 and NNT of 5 is better than 9, because you are just treating 5 patients to prevent 1 respiratory failure with remdesivir when compared to 9 persons with hydroxychloroquine. I hope those who have understood well and good. If you have not understood, I request you to go and read on number needed to treat, per protocol analysis, intention to treat analysis, and so on. Because these concepts are very difficult to remember. Unless you do a randomized control study, you're not going to remember all these things. So that is why I'd be very happy of the 200 of students, odd students who are listening to this. If 2 of you in your lifetime, are able to do an RCT, it would be a fantastic achievement for everybody. Okay. In India, if you're doing a RCT, you're supposed to register under the ICMR. It's called the CTRI, the Clinical Trials Registry of India, where you put in the title, the protocol, you have to upload this. Only then you are supposed to come to the ethical committee. They will ask for the CTRI registration number, and only then you can approach the ethical committee. Once you get an approval from ethical committee, only then you can go ahead and do this trial. Okay, so I've come to the end of this presentation. These are some of the study questions and appropriate design you may have. Burden of the illness, you do a cross-sectional study, a prevalence study. You want to find the prevalence, you do a cross-sectional study. The etiology, the risk and prognosis, you probably do a case control study or a cohort study. For the treatment efficacy or the effectiveness, you do a randomized control study. Okay? Because as a student, most of you are confused what my study would be. Okay, so you need to know what your study is going to be. Many of them do not know the difference between case control study and a cross-sectional study. They want to include comparative study in a case control study. Comparative study is totally different from a case control study, and so on and so forth. So it's very important you know what type of study you need for the research, for your research. Okay, and this is from the Lancet I have taken. This is again explains what your study would be. Your first question is, did the investigate? Are you going to intervene or not? Are you going to give a drug? Are you going to tell a person stop smoking from now? And I'm going, and to one person you start saying you continue smoking. I'm going to analyze both groups separately. So you are intervening. You're giving a. Suppose you go and give a health education session on breast self-examination. Again, you're intervening, isn't it? You're telling them something. And then you study them after 5 years and see who all detected breast cancer early. That is an experimental study because you intervened in between. Okay. But then experimental study, again random allocation, then it becomes an RCT. An observational study, if there is a comparison group, becomes an analytical study. If there is no comparison group, it becomes a descriptive study. In a descriptive study, it can be a case study, case series, and a cross-section study. Whereas in an analytical study, there are two types basically, a cohort study and a case control study. A cohort study is usually prospective, it goes from exposure to outcome, whereas a case control study is a retrospective study which goes from outcome to exposure. And this is the evidence pyramid. The evidence pyramid here indicates which is the best of all your study designs, which is the best study. Okay. Of course, test tube research has the lowest value. Then comes the animal research. Then comes ideas, editorials, opinions. I may have an opinion on treating COVID patients. You can see on WhatsApp, when I treated COVID patients with azithromycin and this was found and that was found. You get so many opinions. So those are all opinions, ideas. Each physician will have his own ideas about treating a COVID patient. But those are all ideas and editorials. It has less value. When you start reporting cases, 1 or 2 cases, then it has a slightly higher value. Case series are a little more high because you are studying a more number of people. Then comes the case control studies, which has a higher value than the case series study. Then comes the cohort study. Then above all comes the randomized control double-blinded studies. So randomized control trial as the, it comes at the top of the pyramid. And finally, there's something called the systemic or reviews and meta-analysis. See, what they do is they take many RCTs. Because suppose you are taking dexamethasone and respiratory failure, already RCTs are occurring throughout the world. So what they do in meta-analysis is they take all these studies and combine them, and then they just make one study and say, this drug is the best for respiratory failure. So that is meta-analysis. Meta-analysis is comparatively easier to do than RCT because you are not doing the study. You're not going into the field, you're just looking at the data and analyzing. But it is extremely difficult to analyze the data and meta-analysis. It requires software, extremely good softwares. You should be proficient with the softwares. And another thing is, suppose you're doing a study on dexamethasone and respiratory failure in COVID patients, there must be around hundreds of studies by 2022. So you need to go through these 100 studies. You need to read up all these studies. You just can't just include one study there. You need to include all these studies and then filter them, and then you come to this meta-analysis. So meta-analysis takes a lot of time, your personal time. You just need to keep reading. It may take 1 or 2 years to go over all these articles. So if you have a team of people sitting together, each of them can go through that article, and then you can cut down on the time that can come. So this is the evidence pyramid. Okay, thank you. I think I've just given a broad outline of research methodology. It's supposed to be an introduction. I've tried to cover RCT a little bit more and a case control study a little bit more, because case control studies I find are the most common studies students attempt to do, but there are many failures and many bias that creeps in, whereas RCT is the gold standard. So I tried to cover RCT a little bit more. And thank you. Take care. Be COVID safe.
Sir, excuse me, sir.
Yeah.
We have some questions in the chat box.
Yes.
May I?
Hopefully I can.
May I read it out? So, sir, the first question is, can we combine different study methodologies in a single study?
That's a very good question. Actually, there are very few studies like this. Sir, at UG level, is it possible to do studies other than case control study or cross-sectional study? Where is that question? Can you show me that question?
The second one, sir.
It's the second one, sir.
Can we combine 2 different study methodologies in a single study? It is extremely rare. I find that 2 different study methodologies are done in a single study. Don't attempt it. That is my advice to you. Don't attempt it as a student, even as a researcher, don't attempt it. Because you're going to confuse yourself. And when your study goes for reviews, the first thing they look at the methodology and they may reject it, stand itself. So better to stick to one methodology. Each study has, one particular study methodology. Each study question as each research question has each study design. So go with that particular design. Don't go with two or more study methodologies for one particular study, for one particular research question. Sorry. So at UG level, is it possible to do studies other than case control study or cohort study? To do better studies than case control or cross-sectional study is extremely difficult at the UG level, because you have exams coming up, you have shortage of time, you are involved in many other activities. Case control study and cross-sectional study are very easy to do. You can finish it off very fast. Whereas all the other studies will take time, may take 1 year or 2 years. It's not so easy to do cohort study or an RCT. Crossover study is, as I told you, let us suppose that COVID patients, I told you about diabetes, no? The effect of metformin and glimepiride, okay? 100 patients are there. Group A is 50 patients, Group B is 50 patients. Group A, for the first 2 months, you give metformin. Group B, you first 2 months, you give glimepiride. After 2 months, you stop both drugs, okay? So that you have to wait for a 2-week period, because this drug has to wash out from the system. And to the Group A, now you give glimepiride, and Group B, you give metformin. So you're crossing over the study, study groups. You're giving, Group A is getting glimepiride now, and Group B is getting metformin now. So at any point of time, at the end of the study, all the 100 participants would have received both the drugs. So then you can actually analyze all of them together and say this drug is better than the other drug. So what is the role of confounding factor in research? Confounding factor is, very difficult to discern in research. Only people who really study and, go. I'm giving you the example of smoking. Age is a big confounding factor. Age is a big confounding factor. You are studying cancers, okay? And age can be a huge confounding factor, because as age increases, cancers increase, as you all know. Whereas you want to study the effect of cigarette smoking on cancer, but it is the age which is actually affecting the cancers. So I've given you the example of cigarette smoking in CA esophagus when you are studying the etiology of alcohol to CA esophagus, because smokers are also alcoholic, and smoking also causes CA esophagus. So confounding factor, as a researcher, you have to discern it. You have to go over it a lot of time. You have to read over it, and only then you will know what a confounding factor is. So in crossover studies, as both receive both drugs, how will we analyze? Okay. See, here we are analyzing the blood sugar levels, isn't it? The control of blood sugar levels. So both groups have received glimepiride. Okay. So glimepiride, the blood sugar levels of the whole group was around 135. Whereas in metformin, the blood sugar levels was 180. Okay, that is how analysis is done. So how important is that methodology should involve measures and exact values? While in a study to find prevalence of dysmenorrhea in regularly exercising and non-exercising people, should involve measures and exact. I didn't understand Bhavia's question. So what is the role of confounding factor in research? Yes, sir, in crossover study, I both received doing early analysis. So would it be a scope of medical students to study behavioral patterns? Last one. Study behavioral psychology for certain things. Certain things. See, psychological study behavioral patterns, definitely you can do. Okay, there are scoring systems. There are different scoring scores for studying behavioral patterns and psychological effects. But I didn't understand what certain. If so, could you briefly tell how the methodology would be? The methodology would be just giving you are actually assessing the patient's behavior over a period of time, probably 1 month or 2 months. You have to ask questions and you have to score that behavior. For example, after exams, are you happy? Are you sad? Or are you depressed? Okay. Now, that is you are assessing the psychological mental status of that student. So the one student will be happy, somebody will be depressed because he's done badly, and so on. So you have to score them, and accordingly you get a score, and that's how it is done. There are many scoring systems that are available online. Please go through that. There was a line, once randomized will be analyzed. Our intention, can you explain what this is? Okay. Intention to treat analysis is, as I told you, you are experimenting dexamethasone and respiratory failure. Oh my God, 12 o'clock. Dexamethasone and respiratory failure. Okay. Now dexamethasone, you started randomization today. You have included around 10 subjects today in your study. Tomorrow you include another 10 subjects. Of these 20 subjects, 5 drop out because they had some family issues. They had some side effects due to the drug. They don't want to continue, or they got shifted to another hospital. They want to go to Delhi for treatment, and they just left you. There can be many reasons. Suddenly they die, mortality. So they just drop out of the study. But when you analyze, you include these people also in your analysis, those who dropped out. Whereas in per protocol analysis, you analyze only those who have finished the treatment. That is, suppose your treatment was for 2 months on dexamethasone. You analyze the treatment at the end of 2 months, only those who have finished treatment. For example, you include 100 patients, out of which 20 dropped out, only 80 completed treatment, only 80 you include. Whereas in intention to treat analysis, you include all the dropouts also, so you include 100. Let me just answer one question there. What's the difference between a comparative study and a meta-analysis? Somebody has asked that. Smithy Jain.
What is the difference between comparative study and meta-analysis?
Yes, I think somebody has asked that. Okay, comparative study is, it is totally different. It is like chalk and cheese. Comparative study is, let us say you just go to the ward and you see patients on metformin, and there are patients on glimepiride, and you take these two groups of people and you just analyze. It's an observational study. You're just analyzing these two people. That's all. You're not intervening. You're not doing anything. You just finish. You're just comparing two people there. It's an observational study. Or you take people on dexamethasone, COVID patients on dexamethasone and COVID patients on remdesivir, and you just analyze them. Whose SpO2 is better and who's clinically getting better, and so on and so forth. It's just an observational study. Okay, so two groups of people, you are analyzing them. Whereas in meta-analysis is the epitome of research actually. Basically, you are taking RCTs from throughout the world. There may be thousands of RCTs. For example, if you take metformin RCT, there must be 10,000 to 20,000 studies done over the past 10-15 years. You take all those studies and then you analyze them and you say that metformin is better than glimepiride in controlling obesity or something like that. Now, I'm just giving examples. So meta-analysis is above RCT because RCT is just one study, whereas meta-analysis is multiple studies done throughout the world. You're collating it into making in one study, and that is meta-analysis.